Well, hello everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic. I'll be moderating the event, and I'll be introducing our speakers as well. Now, as a reminder, this event is one in many in a monthly series of alternating case conferences, educational webinars, so just be on the lookout for some of the upcoming components of this webinar series. Today's 30 to 45-minute case conference will include a brief presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then it'll end with a Q&A session. So on that note, if you have any questions, put them in the Q&A option. Feel free to use the chat for comments, but we're only going to be answering questions that are in the Q&A option. Our trainee presenter today is Dr. Joan Oh. She's a psychiatry resident at Temple University Hospital's Psychiatry Residency program. And our faculty discussant today is Dr. Andrew Francis. He is the professor of psychiatry and associate director of residency training, director of neuromodulation services at Hershey Medical Center, Penn State Medical School in Hershey, Pennsylvania. And without further ado, I'm going to hand it off to Dr. Oh for her presentation.
Thank you so much, Dr. Fipps. I'll now share my screen. Thank you. My name is Dr. Joan Oh. I'm a current PGY2 psychiatry resident at Temple University Hospital in Philadelphia, Pennsylvania. Today, I will be presenting a case report I published as a medical student regarding a case of catatonia that was complicated by COVID-19, navigating challenges and treatment options. So before that, I would just like to acknowledge my faculty mentor, Dr. Ryan Sardinas, our Associate Program Director at Temple University Hospital, in addition to the co-authors who helped publish this case report with me. And so I will just jump right into our history of present illness. This slide here shows that we have a 20-year-old male where we were consulted for altered mental status at time of admission. So on the left-hand most side, 2 weeks prior to admission, this 20-year-old male had returned from a trip to Florida where mom noticed patient was not like his usual self. He was found to be confused, irritable with short-term memory loss, and paranoid with some ideas of reference. 1 week later, he presented to his local emergency room with seizure-like episodes, abdominal pain, and a loss of smell. He was evaluated by the neurology service, who had low suspicion for seizures, and was discharged after a 3-day admission with a script for levetiracetam, outpatient epilepsy evaluation and imaging studies. However, 3 days later, he represented to this local emergency room again for worsening agitation, where he was fluctuating between unresponsive staring episodes and agitation. He was again evaluated by neurology, and imaging studies were obtained, including non-contrast head CT, chest X-ray, and MRI, which were unremarkable. So they found his presentation inconsistent with epilepsy. And it was at this point where he was first found to be positive for COVID-19. He was eventually transferred to the hospital where psychiatry was consulted, after neurology had found this condition to be suspicious for catatonia, after EEG showing no abnormalities, and a repeat PCR showing positive for COVID-19. Moving on to the history, his past psychiatric history was significant for major depressive disorder, generalized anxiety disorder, and autism spectrum disorder, high functioning. He had no specific medical conditions or medications or allergies, and he was fairly high functioning, independent, and employed independently with completed high school and special education classes, and he was living with his mother. He had no significant family or substance use history. When psychiatry was consulted, this patient had significant bedside exam findings, including that he appeared disheveled with poor eye contact. His behavior was uncooperative. He wasn't responding to his surroundings. He was clearly awake, but not responding verbally to any direct questions or commands, and he was completely mute. He was found to be sitting motionless on his bed, and his extremities appeared rigid, maintaining a fixed posture for extended periods of time. We were unable to assess his mood as he was completely mute, but he had a constricted affect. We were unable to assess his thought process. However, he didn't have any overt signs of hallucinations or delusions, and we were unable to assess his sensorium in addition to his insight and judgment. Given these findings, a Bush-Francis was calculated here with a total point of 11 points, where he was scoring points in immobility, mutism, staring, posturing, rigidity, negativism, and withdrawal. And some of the objective studies up to this date were largely unremarkable. His vital signs were pretty stable. His laboratory studies, including blood cultures, comprehensive blood counts, electrolytes, liver function tests, and thyroid function tests were unremarkable, in addition to inflammatory markers. And imaging and procedures were also unremarkable as well, including non-contrast head CT, chest X-ray, lumbar puncture, MRI, EEG, and EKG. As we can see here, the only significant finding was that he was positive for COVID-19. And so moving on, when considering the differential diagnosis of catatonia, it's important to note that the symptoms overlap significantly with delirium, and it's important to rule that out. But in general, we can divide the differential into medical etiologies versus psychiatric etiologies, with medical including things like neurologic, infectious, and metabolic etiologies, and psychiatric involving mood, psychotic, and neurodevelopmental disorders. And so in this slide here, this slide shows the medication titration course during this patient's hospitalization. He had a complicated hospitalization where he stayed at this hospital for 9.5 weeks, or approximately 67 days, as we can see in the first column here, where it shows the corresponding weeks. The second column shows the trend of the Bush-Francis scores. The third column shows the standing medications corresponding to the start of the week. And then the fourth column here shows the total daily dose of the corresponding medications. So we see in the first row that this patient had an initial Bush-Francis score of 11. Thus, a lorazepam challenge was given 1 milligram IV. He had a positive response showing improvement in his mutism and rigidity. He was found to be completely oriented and denied symptoms of depression, psychosis, and mania. However, did endure some anxiety for the past several weeks. He also had some residual confusion about his situation. Thus, he was started on a standing lorazepam, 1 milligram IV every hours for a total daily dose of 3 milligram. And in week 2, aripiprazole was also started as an adjunctive medication. However, it was discontinued by the end of week 2 due to perceived lack of benefit by his mother. And as we could see, starting in week 3 to week 5, his Bush-Francis ultimately worsened. This patient showed a fluctuating decline despite increasing doses of lorazepam. As we can see in week 5, he had a Bush-Francis of 21, which was worse than his initial Bush-Francis, and he was on standing lorazepam 60 milligram total daily. So by the start of week 6, given this partial response and worsening condition, the team had considered ECT. Unfortunately, due to his involuntary status and issues obtaining consent, ECT was not able to be pursued. Thus, the team had considered the addition of an oral NMDA antagonist, amantadine, which was 100 milligram oral twice daily for a total daily dose of 200 milligram. And it was not until the addition of amantadine that this patient showed a gradual improvement starting from week 7 to 9.5, where his lorazepam was eventually titrated down, as we can see in the bottom row, to 27 milligram oral, and his amantadine stayed the same at 200 milligram oral as well. He was eventually discharged with an outpatient taper over several months at this same hospital system. So I have 3 discussion questions for Dr. Francis. Number 1 is, how do we effectively use glutamatergic agents in the treatment of catatonia? Are there any diagnostic features which would suggest earlier integration of these kinds of agents into catatonia treatment? And given the recent lorazepam shortage in several hospital systems, how should we navigate the use of alternative benzodiazepines in catatonia management? And with that, I will pass it along to Dr. Francis for discussion.
Thank you very much, Dr. O. Let me share my screen. So it's my pleasure to be invited to participate in this panel discussion. So I'll be talking about what we know about treatments for medical catatonia. So unfortunately, we don't have good studies. We have case series and expert consensus and opinion. And I'll be talking about the various official guidelines that have been published, some of which I've been involved with. So I would take this as a case of medical catatonia. It doesn't sound like his psychiatric illness had recently flared up or that there was reason to link it to his psychiatric disorder. So I'll start with the ACLP monograph on medical catatonia, which was posted to the ACLP website in 2015. It was later published substantially unchanged. Brendan Carroll and I were reviewers on the monograph and ultimately became co-authors as well when it was published. So the first point is that on a medical service such as this, the most likely form of catatonia would be catatonia due to a medical condition rather than a psychiatric condition. There are, of course, people with psychiatric-induced catatonia who end up on the medical floor for some other reason. To date, We do not know of any particular difference in symptom profile that would help us identify this is catatonia associated from a medical disorder versus a psychiatric disorder. We don't have that data to support any distinction as of yet. So there's nothing about the clinical features that would say this is more likely a medical versus a psychiatric catatonia to use that differential. In this monograph, which reviewed the literature at the time, which is mostly case series and case reports, intravenous lorazepam is the preferred treatment for catatonia, whether it's quote, medical or psychiatric. Amantadine and memantine, NMD antagonists, one of which was used in this case, are considered augmentations or alternative agents. It was used here as augmentation with benzodiazepines. It's important to note that in addition to starting the NMDA antagonists, the caregivers here also escalated the dose of lorazepam, ultimately reaching 27 milligrams a day. ECT, again, these are recommendations from this panel report from the ACLP. ECT often provides remission when medications have failed. And dopamine antagonists, according to this, can be used in certain circumstances with careful monitoring with respect to malignant catatonia. Looking more closely at this report about specific medications and dose ranges. So initial treatment, lorazepam IV, if available, and a titration of up to 24 milligrams a day, which is what was done here, in addition to adding the adjunctive agents to the NMDA antagonists. This recommendation listed ECT as a second option, and benzodiazepines have failed within the first few days, or there are signs of malignant catatonia, that is to say, catatonia with autonomic features, things like fever and unstable vital signs. Memantine and amantadine are secondary agents, or perhaps augmentation for lorazepam. I hosted a panel at the ACLP a few years ago when it was in Palm Springs on the challenges of ECT on the medical floors. It's surprisingly difficult in many centers to actually achieve ECT in the medical setting for a variety of reasons. And antipsychotics could be considered where there are no symptoms of malignant catatonia, and this panel recommended olanzapine as an option. You'll see this evolves over the years. We move forward now a few years to Scott Beach, who's at Harvard, and they published a review specifically for medical catatonia that has not responded to lorazepam or ECT, or where those treatments are unavailable. So these are review of secondary treatments for primarily medical catatonia. And this was a very systematic research effort reviewing literature. Most of that literature is case reports and case series. There are no systematic trials of any of these things, including ECT or lorazepam, in the sense of double-blind controlled trials. And this was published in General Hospital Psychiatry in 2018. So they do, of course, start with the top-line treatments, which are lorazepam. And here there is a recommendation of how to do that lorazepam. Initial challenge dose, the lorazepam challenge, 2 milligrams if IV if possible, and to escalate this over the next few days. These authors recommended a transition to ECT within a few days, and that the ECT be considered more quickly in the treatment algorithm. They then call the glutamate antagonists step 3, that is to say after ECT or lorazepam, or when ECT and lorazepam have either failed or unavailable. Amantadine, again, similar dose, up to 600 milligrams per day, as tolerated, titrated over several days. Or memantine in doses of up to 20 milligrams a day. I have seen people go higher than 20. Step 4 in this algorithm would be anti-epileptic drugs, for which there's very minimal evidence, a few case reports, carbamazepine or valproate. And then lastly, in certain scenarios, atypical antipsychotic agents, and they list aripiprazole, olanzapine, and clozapine. Now we come to the most recent and actually the most comprehensive guideline on catatonia. And this was organized by Jonathan Rogers, who's at London, UK, and a worldwide panel of experts on catatonia participated in this, and we were all co-authors. This was published at last year from the British Association for Psychopharmacology and the Journal of Psychopharmacology. It's a very comprehensive and detailed review of assessment, workup, treatment. And in addition to reviewing this extensive literature, the weighting of the evidence was ranked. So you don't see any A's and B's here. So A rating would be randomized controlled trials or meta-analysis of prospective randomized controlled trials. We don't have that for catatonia. Level B would be prospective open trials, which we have a few of. C would be case studies, descriptive reports. D would be expert opinion. And S would be consensus of experts. So most of the literature base has low evidentiary value. First-line treatments, of course, are accepted in this protocol as ECT and lorazepam. And when first-line treatments are ineffective or only partially effective, a trial of NMDA antagonists are recommended. And when first-line therapies and NMDA are also unavailable or ineffective, consider a trial of L-DOPA, a dopamine agonist, carbamazepine, valproate, or topiramate, or potentially a second-generation antipsychotic. They should be avoided when there's no underlying psychotic disorder or where there's any tendency to malignant features. And some cautions here: potential use of second-generation antipsychotics if there is an underlying psychotic disorder. And surprisingly, with very little evidence, where ECT is indicated but unavailable, consider treatment with other neuromodulation techniques such as TMS or transcranial direct current stimulation. There's only a few case reports on this. A little bit more detail about the medications. Lorazepam is preferred over other benzodiazepines. High doses beyond, quote, maximum clinical use typically may be necessary, as was done in this case, 27 milligrams. Reassess frequently. Adequate trial of lorazepam continues until it's treated. Side effects prevent further dose escalation or the dose reaches 16. Many people would go beyond 16 milligrams if it's tolerated, and that it shouldn't be stopped but tapered, although guidelines of tapering are exactly unclear. ECT is highly effective as a first line within the first two groups of treatment options. More evidence for bilateral ECT. There are some case series of unilateral ECT, but most of the clinical experience and research literature is with bilateral ECT, at least 2 times a week, perhaps more often if it's malignant catatonia, and the usual protocols about use of ECT. Again, failing the first-line treatments, which are catatonia, which are lorazepam and ECT, consider the NMDA antagonists. Here's their treatment outline from this paper from Rogers. It's very complex. It includes special cases where if there's a, quote, known cause, such as benzodiazepine withdrawal or clozapine withdrawal, that those catatonias often respond to replacement of the drug. Malignant catatonia, much more likely to need ECT, but occasionally does respond to lorazepam. And so this protocol suggests lorazepam first, ECT second, reevaluate diagnosis, and then NMDA antagonists. So is there any rational basis to choose between the NMDA antagonists? We published a paper. It was a case report of a woman who had depression and catatonia, who was unable to have ECT. And we treated her with memantine, and we noticed that the cognition improved as well as the catatonia. Her MoCA score improved from 15 to 23. So we did a literature review on other case reports using memantine to treat catatonia, and the question we addressed was, did those case reports give any information on cognition as well? And some of them did. So the implication perhaps would be, between choosing the different NMDA antagonists, memantine might be favored where there's a question of cognitive impairment in the picture or at the baseline. So let me conclude with some observations. Controlled and randomized data are lacking. Perhaps they're not feasible. Very difficult to treat in an organized, systematic way. ECT and lorazepam are top shelf treatments. Everything else is second, third, and fourth line. NMDA antagonists, we might consider memantine if there's known cognitive impairment in the case, either concurrently or premorbidly. So let me stop there and hand it back to Dr. O for
Thank you.
update.
Thank you so much, Dr. Francis. All right, I will share my screen, providing a brief case update. So for our final formulation, our team was most concerned for benzodiazepine-resistant catatonia associated with COVID-19 infection, with other risk factors to consider, such as its autism, depression, and generalized anxiety disorder. And in regards to our team approach, we determined that the combination of amantadine and lorazepam was safe, effective, and tolerable. And this patient eventually returned to his baseline status with the assistance of cognitive rehabilitation, occupational therapy, and a very close outpatient follow-up over several months where his lorazepam was tapered. And that we should consider oral NMDA antagonists such as amantadine and memantine, like Dr. Francis mentioned, especially when ECT is unavailable due to possible glutamatergic hyperactivity in catatonia symptoms. And with that, I will stop sharing and pass it off to Dr. Fipps.
Excellent. Excellent. Thank you both. An excellent presentation as well as a really good discussion. We've already got some questions in here, and I say we go ahead and start. So one of the things you mentioned, Dr. Francis, that was mentioned many times actually in these papers, is that we need to be cautious with using antipsychotics in this context of the risk of malignant catatonia if the individual does not have a psychotic disorder. But it commonly comes up if we're treating psychosis or an individual has a primary psychotic disorder, though there's no guidelines around that. What would be your thoughts about how you would approach that?
So if the catatonia is occurring in a person with a psychotic illness premorbidly, what I would recommend is try like the Dickens to relieve the catatonia completely with the treatments that we've just mentioned, excluding antipsychotic drugs. And if you can achieve that, a second generation antipsychotic of the ones mentioned earlier, very cautiously. There's some evidence from a couple studies that a serum iron level might be helpful in predicting who will have a bad reaction to antipsychotic drugs when it's a low serum level. And closely monitor for extrapyramidal symptoms, catatonia symptoms, and vital signs. So there isn't a big evidence base. This is just clinical experience and expertise on that. But try to delay as long as possible reintroducing an antipsychotic drug in that scenario.
Makes sense. And I think it's a clinical experience is what we can best rely on a lot of times in some of these situations. You also mentioned, the iron levels, especially. Are there other additional recommended tests that you may consider, like if someone's not responding well to the lorazepam challenge or regular lorazepam, would you do more workup after that if they're not responding?
Well, about 2/3 of the patients typically will respond to lorazepam. That's across psychiatric and medical catatonias, sort of as a general figure. And usually in the medical setting, they've had a pretty extensive workup. So as this case had brain imaging, EEG, LP even, basic lab studies. So one might revisit those or add a few that you had already done in somebody who's not responding well to lorazepam. But we do have to face the fact that lorazepam does fail in a third or so of cases. And so then we would consider, so an clinical judgment would be, do we do further testing or do we add an adjunctive agent?
It's a good question. And similarly, there's another question that's very similar to that, is how many times would we recommend repeating an Ativan challenge that may not have been fully identified to be helpful?
Well, the important thing is that if at all feasible, that the lorazepam challenge be intravenous. There's definitely a different absorption with intravenous. It's the only sure way to know it's well absorbed. So if you could consider repeating the dose, the IV challenge.
Excellent. You also, in the same context of Ativan and lorazepam, you mentioned having a good slow taper in that process as well. How would you recommend that we approach a taper, especially someone who was on very high doses of lorazepam to mitigate their catatonia symptoms? How would you suggest the person who's receiving them on outpatient to address this clinically?
Well, this is actually a topic that we addressed at an APA workshop a couple of years ago, where we've struggled so much to get this patient well with catatonia, and they're on 15 to 25 milligrams of lorazepam. How do we sustain that? The best way to sustain that is keep them in your own system, because if you send them to the community clinic, they'll take the view, well, benzos are terrible, let's get rid of them. So if you can send it to your own outpatient center within your own system, where you have some liaison as to why this person is on a benzodiazepine, and be very cautious about a slow taper. What does a slow taper mean? No evidence to guide us. Over weeks, if not months.
Excellent. Helpful. Very helpful. You had also mentioned there's barriers, obviously, to getting ECT on inpatient medical settings, at least. And what would you say some of the strategies would be to maybe address some of the most common barriers that would be out there for that?
If you can succeed in, if you happen to have a person with malignant catatonia in your ICU and you're able to actually get ECT and save that person's life, the ICU nurses will remember that. And they will be your allies administratively. And so this has happened to me at 2 institutions so far. And they say, well, the last time we had somebody like this, those psychiatrists came in and did ECT and they got better in a few days, got out of the ICU. So one is try to do at least an index case. And that maybe helps start the ball rolling. The other is to make good friends with the ECT team.
The L of our liaisoning.
Well,
Absolutely.
in some hospital centers, the CL team actually does ECT. It's not an uncommon scenario that they do the ECT for the psych inpatients. It's a real tragedy. The main problem is that the ECT is not located where the patient is. That's the main problem. And sometimes just being on another floor, they could be 1,000 miles away. It's the same thing. 1,000 miles away, or the other floor, or the other end of the building sometimes. It's amazing.
We have a couple of questions in here about utility or literature base around some alternatives that weren't mentioned there. Is there any literature to suggest that maybe non-responders to lorazepam may respond to zolpidem or to propofol?
Oh, there's actually studies on zolpidem. They're open trials, prospective trials, both in psychiatric patients with catatonia and medical patients with catatonia. These were done in France. And it was 10 milligrams dose, oral or by NG tube, and they show a good acute response. So it's not controlled double-blind trials, but it's open trials with 20 or 30 subjects actually. So it's and quantitative ratings with the Bush-Francis scale. So zolpidem does play a role. It tends to have a more transient effect. So in my experience, I've used it a few times. The benefit tends to wear off.
Excellent. Good. I think we have time for one more question here. Oh, were you going to say something else, Heather? To make sure. Okay. We have time for one more question here. And so sometimes worsening agitation or psychosis is noted as a possible side effect of amantadine. Any experience with a catatonic patient having this side effect? And does memantine also have similar side effects to that process?
I don't think that's very often reported. And it may be relieving the catatonia exposes an underlying psychotic state. So it's not entirely clear when that happens.
Fair. And that was quick enough that we actually have room to answer another question here. Maybe one more question. So do we have an idea of the mechanistic relationship between iron levels and the risk for malignant catatonia that you were talking about? And should iron levels be repleted as part of a global management?
No, it's considered. It's not well studied, but it's considered to be an acute phase reactant. It's perhaps a sign of some lingering inflammation. It's an inflammatory marker, low serum iron, and it's understood as part of the immune mechanisms in catatonia, which were well reviewed in a paper by Greg Fritchone and also Scott Beach, I think 1.5 years ago, about immune mechanisms in catatonia. It's an excellent paper.
Excellent. Well, I think that's about all the time we have for today. This was an excellent discussion. I really appreciate the great case presentation as well as the discussion, question and answers. Thank you, audience, for excellent questions that created a really hearty discussion in that regard. If you're interested in seeing this again, this will be on the website of ACLP. This will be on the CL Facebook group. This will also be on CL's Twitter page, and it may also be placed on Instagram as well. We're enhancing ACLP's social media platforms as well. But otherwise, I appreciate you all being involved, and we'll see you next time.